So today I'm going to present a topic that represents a subspecialty by itself. It's called ocular surface reconstruction. My name is Samar A. I'm the Senior Academic Consultant in Anterior Segment Division, as well as the Associate Director of Research Department. So this presentation is meant to be an interactive. So I may ask you just from time to time just to interpret some of the slides and to answer some of the questions, okay? So I already put some MCQs in the middle of these presentations. Okay, so this is the highlight of our presentation today. I'm going to present a brief, definition of ocular surface health, limbal stem cell deficiencies, ocular surface disease, early management, approach to treat ocular surface disease, amniotic membrane transplantation, conjunctival flap, limbal stem cell transplant, and I will end up talking about the keratoprosthesis. So the ocular surface health, you hear about this term from now until the end of this presentation. The ocular surface, as you know, it's the mucosal lining between the upper and the lower eyelids, which means that we're talking about the epithelial coverage of the cornea, conjunctiva, all the way to the lid margin. And in order to have a healthy ocular surface, we need to have a good interaction between the ocular surface epithelium that have a good function, cornea, conjunctiva, limbus, a good interaction with the lacrimal gland, meibomian gland, and tear film. And all of these are going to give us an ocular and healthy ocular surface, and this will protect also the eye from infection. So one thing just to highlight is that when we talk about the cornea, we always talk about limbal stem cells, and the limbal stem cells are present and at the abilities of focus at the limbus itself. And I would encourage everyone to read about the Taft hypothesis of a corneal epithelial maintenance, how the corneal regeneration takes place. So these limbal stem cells are in charge of regenerating the epithelium. So, and I mentioned that one in one of my past, articles with the title "Graft Failure, Ocular Surface Complication." It's all described there. So, limbal stem cell deficiency is defined as an ocular surface disease caused by a decrease in the population and or function of corneal epithelial stem cell or progenitor cells. So what will happen if we have this entity? If you keep this entity untreated and it progresses from partial to complete, this will end up causing a corneal blindness. So this is why we really need to address this entity, the limbal stem cell deficiency, and diagnose it earlier. What about the other definition? We call it ocular surface disease or ocular surface disorders. The abbreviation that we use is OSD. It's a group of disorders or a group of diseases of diverse pathogenesis in which the disease results in a failure of mechanism that maintain healthy ocular surface. So it's a disease that may affect purely cornea, may affect cornea and conjunctiva, and leads to an abnormal interaction between all these surfaces, the one that I mentioned earlier. And if you want to read more about the ocular surface disease, the Edward Holland, published a nice book about all the ocular surface diseases. I'm going to give you an examples for some of our patients here in KCASH and mostly in Saudi Arabia. For instance, trachoma, it affects the corneal conjunctiva, and you can see here. So it may cause a corneal, diffuse corneal scarring, as you can see here. These are the herpes bits, and these are the arch lines from the conjunctival scarring. And of course, also it affects the lashes and it causes entropion and ectropion. What about this one? It's the chemical injury. It will affect the cornea. A conjunctiva may go also, if it is alkali, it may affect also the lens and also cause a glaucoma. And this is a total a grade 4 chemical injury with total limbal stem cell deficiency. And in this patient, even he lost the eye, it was reticle. It was, sorry, it resulted reticle bye-bye. Another example also, if the patient is not fit properly with a contact lens, this will cause a lens-induced keratopathy, and with the time this will cause lens-induced limbal stem cell deficiency. So this is a very tight lens fitting, as you can see here, and this is an extremely tight lens fitting that cause all the damage to the limbal stem cell and of course to the conjunctiva, and also it cause and dryness. And this is an example of one of the congenital disorders. It's aneurydia, and this is one of the congenital causes of limbal stem cell deficiency. Here you go. This is a Stevens-Johnson syndrome. If it's very bad, it may cause also total keratinization. And then, as you know, also ocular OCP is also one of the disease that cause ocular surface failure and leads to limbal stem cell deficiency and keratinization, as you can see here. So we really need to diagnose these disease early and try to prevent their progression. So let's talk about limbal stem cell deficiency. So the limbal stem cell deficiencies, there are specific signs. One of it is loss of limbal anatomy. You cannot differentiate really a clear limbal zone, okay? As well as persistent epithelial defect that lasts more than 7 days. Scar formation in the cornea. Corneal conjunctivalization means a growth of conjunctiva on the top of the cornea, with or without neovascularization, with a mixture of metaplastic cornea conj epithelium. And the last sign is a diffuse permeability of topical fluorescein into the anterior stroma. So when you apply a fluorescein, normally you're not supposed to have any stain, right? Unless there is an erosion or epithelial defect. However, even when the surface have no epithelial defect or erosion, in these patients, when you put a fluorescein, it will stay for a few minutes after you apply it, because the conj epithelium allows the penetration and staining of the fluorescein. So how can we objectively, identify the conjunctival epithelium that grows on the top of the corneal surface? The gold standard method to identify it is, we call it a cytology, particular impression cytology. So this is an example of the impression cytology that you can see here. So this will give you a clue of cytokeratins that are specific to the conjunctiva. So in the conjunctiva, we can say that there are specific ones like K13, K17, and so on. So these are in specific available in the conjunctiva. They're not supposed to be available in the cornea. So once you find them, this indicates that there is really a conjunctivalization. Another thing, presence of goblet cells. Goblet cells is not supposed to be available in the cornea. It's only available in the conjunctiva. So this is the gold standard method. Another way to diagnose the conjunctivalization is by performing a biopsy, or if you have a high resolution in vivo laser confocal microscopy, you can also identify the conjunctival epithelium. Now back again to the diagnosis. So now we know what are the signs and how can we objectively diagnose a limbal stem cell deficiency. What about dry eye disease? So dry eye disease, for those who are working with us in cornea clinics, they'll notice that we use a fluorescein. However, we use a different type of stains because fluorescein to us is not the optimum one. We prefer to use the alisman green or rose bengal stains, and the staining by these two stains is much specific and more superior to the fluorescein. And here is an example of rose bengal staining in a dry eye disease, and this is a alisman green. And the most specific sign in dry eye disease is the stains that takes place in the interpupillary fissure. Okay, so this is where you're gonna focus, is the interpupillary fissure, mainly in the conjunctival side, because if it is corneal staining alone, it indicates that it has progressed even further and further, so it's more advanced stage. And one thing that also you need to know, that if it is only localized to the nasal conch, this is non-specific sign. Okay, so you have to focus on the staining pattern. Another test that we used to do in the past, we call it Schirmer test, whether type 1 or type 2. It's non-objective and it's not specific anymore for dry eye disease. And nowadays, the gold standard one is the what we call tear composition analysis. By performing a tear osmolarity, and has a specific number. If it exceeds 302, whether with plus or minus 6, or there's a disparity between both eyes, and some inflammatory biomarkers. If you take and tear samples and check for the inflammatory biomarkers, MMB9 and lactoferrin in particular, they will be elevated in patients with dry eye. And this is an example of the how we take the tear samples and subjected to a tear osmolarity test. Okay. Then after that, we can do also a serum antibody testing if we are thinking of, like, a Jugurin type 1 or type 2, and RF anti-RO, anti-LA for Jugurin diseases. You can do also further do something called tear film structure and image analysis in myelonography. Myelonography is just this is an one of the growing test that we're performing nowadays to check the myelonograph of the lids. Specifically, we do it for the lower lids, and we can grade that one from 0 to grade 4. As you can see here, the flow of the sebum is very clear, and here is slightly, it's going to be obstructed, and here you will see less obstruction, more obstruction, and then until you see atrophy of all the meibomian glands and no flow of the meibomian secretions at all, and so on. And this can be done by different machines like a keratograph. Tear film also, we can measure also the tear film itself. So now we come to the first test, and I need one of the volunteer to answer. All statements are true except. Anyone wants to take this? Rama? Can you hear me?
Yes, doctor, yes.
Okay, who wants to volunteer? I don't hear Rama. I know it's a noon time and you may be exhausted, but we need somebody to volunteer. I'm not gonna move on until somebody volunteer. Anyone from the Air Force?
السلام عليكم دكتورة.
عليكم السلام. هلا حياك الله.
الله يحييك. So the question is all statements are true except that.
وليد خياط.
Yes, وليد خياط are true.
حياك الله. اتفضل.
الله يحييك. All statements are true except function of vegetative cells may be reduced in limbal cystic deficiency. Corneal epithelial biopsy is the golden standard to detect conjunctivalization. Tear osmolarity test is a standard test to detect D and P. D is a sign of limbal system deficiency.
Okay.
So I think one is not true.
So what do you think the answer? What's the definition of limbal stem cell deficiency?
The definition of limbal stem cell deficiency is loss of the progenitor cells. So
okay. So as I said earlier, so when we define it, we said that it is a loss in the number of the limbal stem cell progenitor cells plus or minus their function. So their function may be reduced also as well. So they are available, but for some reason they are not functioning well, like for instance, in patients with congenital aneurydia. Okay, so this statement is true. Okay, so which one is false?
So I think regarding the standard way to test for conjunctivalization, we said we do cytology, impression cytology.
Correct. So yeah, so impression cytology is the gold standard test to detect conjunctivalization. Well done. Okay. So let's move to the next slide now. So now we just, highlighted the summary of all the definitions of important ocular surface disease, limbal stem cell deficiencies, and how do we diagnose the dry eye disease. And by the way, DED is the well-known abbreviation to describe dry eye. So we don't say just dry eye, we say DED in general. Anyway, so how to handle a patient who have an ocular surface disease and do the ocular surface reconstruction. So there are a few steps that we need to start. So we have to start in stepwise approach. First one, we need to suppress the inflammation. Then we need to eliminate the toxic medications and to control glaucoma. And then we need to maintain a wet surface and to correct an eyelids or eyelash abnormalities. And that we need to protect the integrity of ocular surface from any further harm, that we need to promote the ocular surface healing, and then we need to restore the globe integrity and covering the unstable ocular surface. And lastly is one of the very advanced way of doing the treatment, that is the surgical treatment of limbal stem cell deficiencies. After you achieve all the above, then you can categorize the limbal stem cell deficiency into two, whether it is unilateral or mild bilateral disease, or if it is unilateral, and bilateral mild, or if it is bilateral advanced. Unilateral means like in one eye, bilateral means both eyes. If it is mild, bilateral stages means like only localized to the periphery. Okay, but if it is bilateral, if it is severe unilateral or advanced bilateral, meaning it affects also the center of the eye, then we will have a different way of surgery. So in the mild forms, we can just do the medical treatment, contact lens, and then and if it is progressive, we can do sequential removal of the sick corneal epithelium and banus, with or without amniotic membrane. So that's for if it is unilateral or mild bilateral limbal stem cell deficiency. What about if it is severe unilateral? Okay, and after you have done all the above measures, then you can do an autolimbal stem cell transplantation. Okay, and we will describe it later. If it is a severe bilateral disease, then you can do specific types of limbal stem cell transplantation. Although it's not from the same eye, it's from not from the donor or from relative, or you can do an artificial corneal transplant. We call it keratoprosthesis, or we can use the mucosal coverage of the from the eye as a resource to provide a stem cell called COMET. So let's now discuss each entity. How do we suppress inflammation? We can do that either topically or systemically. Topically by using steroids or steroid-sparing medications such as cyclosporin or tacrolimus, or by applying amniotic membrane. Systemically, we can suppress it in a younger patients and try to avoid a very heavy systemic suppression in elderly and chronically immunocompromised patients. So we can use a pulse therapy of acute acute stage of pulse therapy of prednisolone, or we can use, and then followed by a short tapered course of oral prednisolone. In a chronic condition, we can use the calcitonin blockers such as tacrolimus or cyclosporin, or we can use mycophenolate medications. And the second step is that you need to eliminate any toxic medications and control the glaucoma. And when we say eliminate toxic medication, really in patients, if you have the preservative medication, this is the best if you have more than 6 bottles to give to your patient, and try to avoid benzalkonium based bottle medication, and make sure the patient is not applying any herbs like germis or ethmet or anything, and also avoid irritated cosmetic agents. So we can prescribe preservative-free medication. We can use a variety of lubricants in the market, lipid or osmoprotected, and in some cases even we stop all the medication that patient is applying, and we call it a wash-up period of as much 7 to 14 to avoid all the toxicity by applying only lubricants, pure preservative-free lubricants. And how we maintain a wet surface? Of course, applying a tear film substitute or lubricants is not going to be enough, and if the patient have really a moderate to severe stages, sometimes you need to use the autologous serum because it has its own nerve growth factor. It has a plasma-rich, components in it with different concentration, or even we can use the PRP itself, similar to the used by a dermatologist. So we give it to the patient in bottles. Okay. The other thing is that really you need to treat the meibomian gland dysfunction, the MGD, because it causes a significant tear film instability. So start medically, and then you can use the sophisticated machine like IBL or LipiFlow or any other automated thermal pulsation. And this is an example of one of the patients who have meibomian gland dysfunction. You can also apply punctal occlusion, whether temporal, like here, punctal plug, or permanent to allow more tear film stagnation. And in patients with alacremia who have absent lacrimal gland or Stevens-Johnson or MMB, we can do also salivary gland transplantation from the mouth to the eye. How to maintain a wet surface, in addition to all the strategies that I highlighted, you can use even mild steroids like isofis. You can use topical cyclosporin with different concentration. You can use the Xiidra or Levitsigrad. It's not yet available in Saudi Arabia, but it's well used in North America. Also, it works on the T cells. You can even use in patient neurotrophic ulcers some of the human nerve growth factor called the synergermin, which is about to be registered here in Saudi Arabia. If you have a lot of filaments, you can use N-acetylcysteine, and you can use vitamin A ointment also on keratinized surface. Then the second one is that you need to correct any eyelids and eyelash abnormalities, because the eyelid the function is not only protection, but also if you have abnormal eyelid margin or lashes, this will increase the erosions on the surface and may cause further depletion of the limbal stem cell. So you don't want anything to rub the eye or cause exposure or cause evaporation of the tear film. The symplepharon is very important if you are planning for any corneal surgery, because this will allow us to proceed further and put a contact lens and apply medication carefully. You can do the use amniotic membrane or mucous membrane with symplepharon ring. Okay, and if you have an exposure, then you can use a tape, or you can do a tersaraphy like you see here in the picture, a temporal or permanent, or you can apply botulinum toxin to cause ptosis. You can also the cyanoacrylate tissue adhesive to the lid margin to cause partial closure of the lid margin. If the patient have a lack of thalamus, you can apply the gold implant, and you can need to correct really the ectropion thin or misdirected lashes. And all of this cannot be achieved really without a collaboration of our colleagues in oculoplastic. So in order to manage an ocular surface disease, the cornea specialist cannot work alone without support of oculoplastic or oculoplastic, and sometimes also rheumatologist for the immunosuppressive agent. Then we need to move to protecting the integrity of ocular surface. In some of these patients, in order to prevent the recurrent erosions, which is one of the signs of limbal stem cell deficiencies, and you need to apply certain type of contact lens that do not cause hypoxia, that is not going to cause any further loss of the limbal stem cell. And in particular, the silicone hydrogel and or scleral contact lens like Bruise, and they have different designs, and they really protect the cornea from erosions, from dryness, and from the abnormal lid margin, and so on. And this is really the trend in North America and Europe nowadays. Or you can prescribe a moist chapter chamber, or you can apply amniotic membrane. Then we move on toward the promote the ocular surface. Another thing is that how to treat the corneal epithelial defect and how to prevent the melting. You can do that one also by applying a cord blood and amniotic membrane extract eye drops. These are available, by the way, commercially, but it's not yet registered in Saudi Arabia, but available in North America widely, and also in Italy. And I give you some example like Genesis, Kivra, the Italian one, and Regeneer Eyes in USA, and so on. And they have a lot of rich really nerve growth factors and a lot of factors that facilitate the healing of the epithelium. And give nourishment to the cornea. Or you can also treat the persistent epithelial defect and prevent further melting by applying amniotic membrane. For instance, if you're talking about the acute chemical injuries, or in case acute Steven Johnson, amniotic membrane is really needed in the first 72 hours. And you can read the chapter that I participate in Jacobics with Dr. Wagner, and we described how we treat the chemical injury, because this is one of the most common disease that presents in the emergency room, and you are the one who are seeing these patients. So if you follow all the treatment regimen, you will be able really to achieve a good prognosis. So then moving toward restoring the globe integrity and covering unstable ocular surface. Let's say if there's a perforation, okay? Let's say if there's a perforation in the cornea, we're talking about the cornea. So if the corneal perforation is less than 2 millimeter, you can apply cyanoacrylates. Again, this is one of the most interesting articles that describe 3 techniques. So I know that also in emergency room, you may have some dermatocele or corneal leak and so on. And then you may be called at night to see some of these cases, especially the senior resident. So please try to do some with the fellows. And you can do that one by drying the epithelium around the area that have leak, okay? And then you apply directly the cyanoacrylate, either directly from its cannula or with the help of the tip of 3 gauge needle. Another technique that can be applied mostly by the anterior segment fellows is that we punch the surgical drape, by 3 millimeter punch, okay? And then we take the sponge, the spear itself, the surgical spears, and then we put an ointment, maxitron and so on. So this spear will stuck to this surgical drape, and then we take the glue to the back surface, and then we apply it directly. So this is also one of the popular ways. Least popular is just to use the cannula, 3 gauge cannula with a very blunt tip. We don't have it, and instead of applying using the sphere, and do the same steps. And if you have, and this is an example of some of our patients, so look at how this cyanoacrylate spread it very clearly, and here a desmatocele with leak, and this is the picture after the glue, and this is a patient who underwent a multi-layer amniotic membrane for small perforation. So you can use multi-amniotic membrane layers, or you can use umbilical cord patch also layers to close the perforation. And the future, probably you're gonna use some of the collagen vertigel if it is available commercially. So now we talk about how to treat corneal perforation. Okay, so we say that we can use the glue. If it is small, we can apply even Conjugate Flap or amniotic membrane or umbilical cord patch. What about conjunctiva? If there is a conjunctival loss, so you can use autograft from the same or from the other eye, or you can use Conjugate Flap, L or U shape, or you can use oral mucosa or nasal mucosa, amniotic membrane. If you have scleral thinning, you can put a scleral allograft, allo from a donor, or corneal allograft from a donor, or you can use pericardial patch, but you cannot apply, a glue simply to close a scleral perforation or amniotic purely. You need really to have a tough structure to close it. And this is an example of a patient who's post-pterygium with application of high dose and long duration of mitomycin that resulted into, as you can see, scleral thinning. And this is the appearance of my patient after applying scleral patch. Cosmetically, it's not very nice, but we can use the pericardial patch if it was available, but it was not at that time. Another way is that also to, just to summarize, all these biomaterials. So we say autologous conjugative, oral mucosa or nasal mucosa, amniotic membrane. There are a lot of different features that differentiate each one of them. However, I need really to know that none of them can replace limbal stem cell except the oral mucosa and nasal mucosa. They may have some stem cell, that can replace partially our corneal stem cell. The rest of it is like, differences like autologous serum is semi-transplant, the oral mucosa is really opaque and cause a lot of mucoid secretion. Nasal mucosa also, it will be opaque on the corneal surface, and amniotic membrane is the most transparent one, and so on. Now, this is our second question. I need also a volunteer, please. Who wants to volunteer? You want me to read it? It's correcting eyelids or eyelash abnormalities are needed prior to initiating anti-inflammatory treatment in ocular surface disease. True or false?
السلام عليكم.
عليكم السلام.
Answer number 1 is true.
هذا القحطاني صح؟
Yes.
إيه هلا دكتور هذا. Okay. So which statement is true?
Number 1.
Is it true? Is it needed prior to initiating anti-inflammatory treatment?
Yes.
Okay. What about the other one? Amniotic membrane can be used when releasing symplepharon surgically?
It can be used.
It can be. Okay. Cyanoacrylate glue is effective in sealing scleral perforation?
Corneal perforation.
Okay, so this is wrong. Autologous conjunctival graft has epithelial stem cell?
No.
It's the nasal, yes, or oral mucosa. So
Nasal
this is
or
wrong.
oral.
This is wrong. Amniotic membrane can be used. And for the first statement, really, we need to initiate the anti-inflammatory medication before moving to correcting the eyelashes or eyelids abnormalities.
Oh, yeah. Yes, it's the opposite.
It's the opposite. No problem. Okay, يعطيك العافية.
Thank
So, I think because of the time, so we need to move it fast. The amniotic membrane transplantation, I published all the techniques and the properties of the amniotic membrane and the Miegio that summarize all the properties. Of course, as you know, amniotic membrane, it promotes epithelialization, it reduces the pain, it has anti-inflammatory effect and also antimicrobial, effects. You can use a fast amniotic membrane preparation. We call it a Brochera. And that lasts for longer period. It comes as a ring and we apply directly to the eyes. Expensive and it requires a deep phoresis. Or you can use also and freeze the dry amniotic membrane as a bandage contact lens. It's, as you can see, it's like a disc shape, and just soak it in and put 1 drop of PSS and apply it on eye. It works as a bandage contact lens. Here's some video of the cryopreserve. This is the commonest one that we use to restore the ocular surface, and especially in the case of the thinning, not only for the healing. And this is the spear. So when it is sticky, this is the stroma side, and if it is less sticky, it's the epithelial side. So usually we prefer to use the sticky side on the corneal surface, the stroma, where most of the nutrients there. The techniques, we can use it either as an inlay or overlay, or we can use a combined, or here a technique to use to describe to release the symplepharon in my article. This is an example of one of my patients who have a limbal dermoid, right? And this is and it's a huge one, as you can see here. It's covering the cornea. This is a pediatric. So the patient was presented really late, like she was at the age of 3 to 4 years to me. So I've done the bulking with multi-layer amniotic membrane. I didn't do any keratoplasties, and then I was even able to debulk the superior lesion at the same time as the first stage. And this is in limbal dermoid before and after with limbal with amniotic membrane. And this is a patient who sustained a perforated corneal ulcer, requires an eye that have a severe limbal stem cell deficiency. And we did the PKP with the a therapeutic with the amniotic membrane to suppress the inflammation. And here the patient who have a pseudophakic bullous keratopathy and underwent a PKB, then failure, then edema, and then we're trying to promote the adhesion of the epithelium and this by doing the stromal puncture and then applying the amniotic membrane to the surface and suture it. And this is another patient with the dermoid, as you can see here, just trying to highlight the dermoid itself, and then we start with the conjunctivotomy around the lesion. So not every dermoid really you need to do the a lamellar keratoplasty or PKB itself. And here I'm trying to excise partially the dermoid from the limbus, then after that one, control of the bleeder, and then applying multi-layer amniotic membrane using the fibrin glue as well as the suture. So here on multi-layers is more than one layer because I wanted to augment the cornea. So because of the thinning at the site of the cornea. And this is really the picture of the patient post-op, and most of this disappeared with the time. And this is the beauty of it, as if you are adding a stroma to the severely thin cornea at the surface, and avoid all the astigmatisms and all the complications of the lamellar keratoplasties and so on. And this is the last one, and also fibrin glue applied also at the tip. So and this is in patients with Moran's ulcer, because then one of the procedures is called conjugate resection with amniotic membrane. So we recess, here we do 360-degree conjunctival periotomy, and then we resect the abnormal conjunctiva that is in adherent with the limbus, because we know this is the sick one. This is the cause of the antigen presenting area. So we resect it and then we recess it, and then we put amniotic membrane to suppress the inflammation on the sclera in the cornea, and we tuck it down, and then we suture it or put also a glue, a net glue as well as suture in order to stick very careful. And then we close the conjunctiva, but keeping it a little bit recessed, and then apply one on the top of it. Okay, so this is a picture of before the Moran ulcer. You see how the eye is extremely inflamed, and this is the picture after the procedure with less inflamed down. Also in patients with the peripheral ulcerative keratitis. So this is the area where the patient have the peripheral ulcerative keratitis. So we're again excising the abnormal conjunctiva adjacent to the limbus, and then we put the amniotic membrane and we measure it really carefully, and we can put more than one layer to suppress the inflammation and augment the thin abnormal area. It's really very, I mean, like, a nice biomaterial to restore the glow. And this is the same patient before and after. You can apply multiple amniotic membrane, and then these are complications of it. It can cause granuloma, it can cause amniotic membrane dehiscence, microbial keratitis can develop also after amniotic membrane, because some patients there is either partially non-treated corneal ulcer underneath it, or the patient is not using an antibiotic, or there is a contamination from the contact lens, hematoma formation. So here a granuloma, and this is hematoma, blood under the amniotic membrane. You can hear an infection, and this is also the dehiscence of the amniotic membrane. So now this is the other question. I need one of the volunteer to respond. Anyone wants to volunteer? Please unmute yourself. We're waiting for somebody to volunteer.
Yes, Doctor, I can answer this one.
Dr. Mohammed Dibasi.
All statements regarding amniotic membrane are true, except the answer is the first choice.
Infection never develop after its transplantation since it has an antimicrobial properties. Okay, what about it can be used to seal small corneal perforation?
Yeah, that's true.
Okay, freeze-dried form can be used as a bandage contact lens? Yes,
I agree. That's true as well.
Okay, it helps in suppressing inflammation and acute chemical injuries. Yeah, correct. Dr. Dibasi. Okay. Let's move to the next slide now. What about the conjunctival flap? This is one of the also one of the popular procedure that we do. Either we do a total conj flap, we call it Gunderson flap, that was prescribed a long time ago, 1958, or we can do a partial conj flap. These can be done only if the eye have no active microbial keratitis, or also in cases with non-autoimmune keratitis. So if there is autoimmune keratitis like rheumatoid and so on, don't do conj flap. It's not going to work, or if there is a corneal perforation, also is not going to work. So these are the contraindication for conj flap in general. And this is the popular article described by Harvard group, where they describe all their outcome of the total conj flap. So which patients we're going to do this procedure and which patient will benefit from it if there is a little visual potential and if there is a chronically irritated corneal surface. Remember, as I said earlier, the conjunctiva, if you cover the cornea by a conj, it's going to be opaque. Okay, so really this is going to reduce even the visual potential if you apply it in a patient who can see very well. So use it in a patient with low vision in general. If there is a chronic sterile epithelial and stromal ulcer like herpetic, chemical, and neurotrophic, and neuroparalytic, or exposure that's not responding to all the previous, procedures, you can do this one. If unstable but closed corneal wounds, you can apply it, or painful bullous keratopathy, or also in enthesical eye with the defects on the surface. And this is the technique how we do it. We just put a traction suture downward. The eye will be placed downward, and then we measure the white to white, and we see how much white to white vertically, and then we go and then we do inject the local anesthetic, and we use only the conj, not the tenon, and we start dissect the conj from the tenon. Let's say if it is like 11, so at least we need to go like 12 or 13 millimeter, okay? And then we take that one, and then we put it downward, and then we close the whole conjunctiva, and this will stay there. So it will be here will be tenon, and here the conj that you put it downward, and you suture it to the limbus. So this is the appearance of one of my patients after having it. You see how opaque it is. This is the fresh appearance after I have done the Gunderson flap. This is another patient who sustained a melting, not responding to a lot, and then I done for him the conjugate flap, and this is the appearance of the eye. No more melting, no more epithelial defects on the eye. Partial conjugate flap, you can just do a simple advancement. You can just advance it directly, or you can do single pedicle like this, I call it a cut, or you can do bipedicle. We do that one, by the way, in certain cases. Let's say if there is like, a Dylan effect, and you in the peripheral cornea and you want to cover it, you can apply that one very carefully. Or here you can use it in a patients where you don't have enough conjunctiva really to cover the whole corneal surface. So for instance, here a patient who have chronic neurotrophic keratopathy, underwent multiple BKs and with recurrent erosion of the graft, and then finally we decided we're going to do the bipedicle. So I can see here, this is the appearance of the patient after the bipedical conj transplantation, and the surface became very stable after that one. The conj flap is not free of complication like flap retraction, hemorrhage, epithelial cyst, ptosis, and satisfactory cosmetic appearance, as I said, and also it reduced the best correct visual acuity to 20/200 or less, and there is an insufficient glaucoma absorption or antibiotic absorption if you apply it. The other procedure that we may do in advanced cases of limbal stem cell deficiencies are called limbal stem cell transplant. In case of unilateral one, you can use the gold standard. We call it conjunctival limbal autograft. So we take a conj graft from at the site of the limbus from the good eye and transplant it to the disease eye. Okay, so this is the first one. The other one is that you can use the simple limbal epithelial transplant. This procedure is called a slit. Or you can use the ex vivo cultivated limbal stem cell, the cultivation on the amniotic membrane or other surfaces. And this is an example of when a patient who underwent Clinton K-Cash when we had the limbal stem cell unit functioning, but the patient developed an infection, and this is the appearance post-op. If it is bilateral, then you can do conjunctival limbal allograft from either a living related or or from the cadaver, means like from the donor, or you can do the limbus as well as cornea transplant from donor tissue for minimally to moderate conjunctival disease, or you can do a culture oral mucosal epithelial transplantation. We call it a comet, okay, from the mouth and to cover the whole corneal surface. And this is the claw. As I said, we take two pieces from the one piece or two pieces from the normal limbus, and then we transplant it to the disease eye after we excise the tissue at that site. And this is just, fast description of it. So this is how we harvest, the conch with the limbus from the good eye, and then we transplant it into the disease eye after we excise all the banners there. And this is the appearance post-operatively. And this is another patient also before and after claw. Claw was done here in Kikash long time ago, and also I published the outcome with one of my residences at thesis, where we check the claw from the autologous and versus from the donor, and then we found the survival rate up to 108 months, up to 87 in the claw, and so it was disencouraging in if you use the donor. And this is the usual, by the way. Anything comes from the same eye, usually survival rate is very high. Anything from the living related or from the donor, the survival rate is very low, and then there is also a risk of from using long-term immunosuppressant medication in this procedure. So anyone wants to volunteer here? Which statement is true?
السلام عليكم.
عليكم السلام.
أهلا دكتورة. The first statement.
باقي ها؟
أيوه.
اتفضل.
The first statement is contraindicated to use it in autoimmune keratitis. Second statement, total conjunctival flap is effective in treating painful bullous keratopathy. This is the correct statement. The third statement is used in unilateral.
It is unilateral, yes, the claw. Okay. And the fourth?
Cultured oral mucosal epithelial transplantation is the first choice for a unilateral. No, we said conjunctival limbal autograft.
Okay, so it's used for the bilateral. Correct. The last procedure, we call it keratoprosthesis. Keratoprosthesis or KBRO is an artificial cornea, and it can be used as a primary or for a failed keratoblastis, okay, with the good phoresis. And there are up to now 3 popular, keratoprosthesis in the world: Boston type 1 KBRO, Boston type 2 KBRO, or osteodontokeratoprosthesis. And of course, there are few that are less popular with the short-term survival, like Keraclear and so on. We're not going to discuss in detail about these types. So Boston type 1 is the commonest. And I will show you the picture of each one of them. The indications of these artificial cornea or the KBROs are corneas at risk of rejection following PK, cornea with factors predisposing them to endothelial failure after PK, like tube shunt or hypotony, or patients with ocular surface failure and limbal stem cell deficiencies, and adequate visual potential, intact nasal light projection to exclude end-stage glaucoma. So these are the indications. There are patients who cannot benefit from keratoprosthesis, like an advanced autoimmune ocular disorder, Steven Johnson, or OCPs with the severe dry eyes and keratinized surface. It's not going to work at all, or end-stage glaucoma. So this is the Boston type 1 KBRO that is available here in KCASH and in many places in the world. And usually we do it if the visual acuity is less than 2400 with the limbal stem cell, and with impaired vision in the other eye. So we really need to save at least one eye for the patient. And these are the indications like herpetic, ocular trauma, aneurydia, and multiple failed BKs, eyes or toxic related limbal stem cell deficiencies, echises, or large ocular surface tumor resection. So this is the implant, we attach it, this is the implant with the platinum, and we attach it to the, this is the back blade, okay? And this is attached to a donor cornea, and then we suture it in the eye. And this is the appearance post-operatively. So this is how sometimes the cornea new vessels and all this grow toward the donor cornea, which we don't care about. Anyway, it was nice presenting this lecture to you, and hope to see you soon. Take care and stay safe.